Good morning, everyone. Thank you so much for having me. I'm not a big social media person, but I do understand that this be real thing is a thing that people do. I don't know how many of you do. How many of you do be real? My daughter does it. So what you do is you take you get a notification at some point during the day, and you have to then pick up your phone. You've just got a couple minutes to do it. And then you take a picture of your surroundings, and then it's a selfie. So what it is essentially it's that moment in time, what are you doing, and then what are your friends, your social media friends doing? So I probably should be doing a selfie with my dental therapy friends here, and then myself up here. So that is where we're getting kind of the Be Real Orthodontics title. So thank you all very much for having me. It was great to come last year to this event, and then also wonderful to be back this year presenting. So, and thank you to my team, Zach and Jenny and Leah, for being here this morning, getting up early. They all got up a touch earlier than me, so I came a little late. So thank you all for having me. So our mission at Smile Orthodontics is to inspire a lifetime of confidence. And so first of all, that's for our partners, all the people who work with us. We're constantly looking for ways to inspire our existing partners with confidence in their work life. And then also for our patients, that's kind of the bread and butter of what we do. We're trying to give our patients a beautiful smile that's going to last a lifetime for them and inspire confidence in them. And then our third constituency that we think about is our referring partners and the communities that we serve. And so we are doing three things that I think will resonate with the dental therapy community. Our Smile Orthodontics has a commitment to the underserved, and that's underserved patients, but also underserved dental practices, and also one might argue that the dental therapists are somewhat underserved by traditional orthodontic practices. We also have a team approach to care in that we have a couple orthodontic specialists, we have general dentists like myself, and we have dental assistants and then clinical support, all working together to deliver care. And this is not unlike the dental therapy model where you're all working in a team-based approach to care for your patients. And then lastly, one of our three uniques is that we have all digital treatment plans for our patients. So whether we're doing clear aligners or fixed brackets, which is 95% of our cases, we have custom digital treatment plans for all of our patients. So that's a little bit about Smile Orthodontics. Our 10-year vision, where we're going as an organization, is to be within 15 minutes of our metro area patients. Currently, right now, we have people driving for a decent distance to come for their orthodontic care. So where we have kids coming from St. Cloud, that's an hour and a half drive for a 20-minute appointment. And then they're going to hop in the car and go an hour and a half back, and they're missing school, and parents are missing work. And so we're committed to just getting closer to our existing patient base. That's within the metro area and then outstate as well. And currently we're in Stillwater, Maplewood, St. Paul, Minneapolis, Maple Grove, Coon Rapids, Otsego, and then Eden Prairie just right at the start of 2024. So now here's the be real part. As I said, it's a team approach, so we'll have some cases up, and then we're going to see some of my partners there that are helping us kind of carry out the treatment plan. So this is some of our team up in Coon Rapids. And really what we start with in orthodontics is we start with orthodontic records. So that is 3 facial photos, extraoral photos of patients, and then we've got the 5 intraoral photos of our patients. And then we are going to take a panoramic x-ray for all of our patients. And then we're going to take a cephalometric x-ray, lateral ceph. And so this would be something that's not going to be very common for you all to see in your practice. You're typically doing bite wings or a panorex. You're not typically looking at the ceph. And we're looking at this for growth pattern and patient's facial type. And we're looking at where they are now and where do we predict that they're going to be from a growth standpoint. And on the upper left, we have our smiling Maplewood crew. And then for our ceph, we'll also do this ceph tracing, which just helps us understand the inclination of the incisors and the molars and the position of the jaws relative to the face. Any of you worked in orthodontics before? I know Darlene has. So Carol here, upper left, she picked up all of the brackets and spilled them all, and now she's putting them all back together. This is a good way to kind of learn which bracket, which is the upper right, and we do the Palmer system. So which is the upper right 1, which is the upper right 2. So tooth number 8, 9. So this is Carol learning how what brackets are what. And then lastly, too, we would do a digital scan for all of our patients. This is just the initial records, what's their occlusion like. And so, and then we'll just do this little heat map, too, so we can see where their occlusion is. And so today, we're going to look at some facial types. We're going to look at some extraction patterns, see a surgical case, do some case reviews, and at any time if you have any questions, feel free. Just raise your hand and I'll call on you. So this is the start of no more alginate impressions. It used to be that we would do alginate impressions for our patients, and the assistants would be taking those initial records on a young child, and they would be crying and gagging, and then I would just go kind of cower in my office while that all passed. Doing all kinds of techniques like breathing, ha, 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 whatever it was, I didn't want any part of it. And so now, no alginate, it is all digital. And this is the start of, yes, Darlene, question? Sure. So most of the times, Darlene's asking about what is medically necessary, and so what cases are going to get approved. And so we have that criteria that we, on our questionnaire, that when we will see our patients, we take these same records and we send these same things in: photos, pans, ceph tracing, and the occlusion, the models with the little heat map. And if this patient was, if their lower incisors are biting on the soft palate, that's something that gets approved. If there's, I think they call it disfigurement of the teeth or jaws, things that impair with biting function, anterior cross bites. And then I tell the patients and or parents, probably more oftentimes this is the parents, that it's some of those criteria and whatever the reviewing dental consultant maybe had for breakfast that morning, what type of mood they're in as to whether or not maybe the cases get approved. And so if they come back and it looks like one that should be approved and it didn't, then we'll appeal on behalf of the patient. But we're trying to send in a narrative each time. Patients and parents can also appeal themselves, but sometimes it's class 1, everything looks good, and they might want treatment, but that's just cosmetic and elective at that point. Okay, and so when we're taking these records, this is just how we think about our cases and how we look at them. We start from the biggest and then we zoom in. So I think of it kind of macro, mini, and then micro. Here we've got Allie and Chelsea up there with one of their favorite patients. She's special needs, so we kind of book extra time for her. And last time there was a lot of hand holding and dance partying, and this patient wanting to invite her two best friends to her birthday party. But so first we're looking at the patient, we're looking at their face, and we're looking for symmetry and dental facial balance and position of the lips and the nose. And then we're zooming in closer to the smile and the incisor display. And then we're looking down the buccal corridors. At the occlusion, we're looking at how much smile display there is. And then we start getting into the micro, and on this particular young man, we're looking at just some of those little enamel irregularities on the incisal edges of the upper anteriors. And so we'll either polish those incisal edges before we do our treatment planning, or along the way, or just kind of right at the end. Most of the time we'll just do a little enamelplasty to line everything up. And then question that everyone has, and I was here not very long and already had a question about phase 1 orthodontics. So we do very, very limited phase 1 treatments. The cost benefit is the same whether the patients are public assistance or fee-for-service. It doesn't really matter. It still is anywhere from $2,500 to $4,000 for potentially limited benefit in most cases. So there's lots of kids who kind of go through that maybe just like a little awkward phase, and if you go into a 2nd and 3rd grade classroom, it's a hot mess, and there's teeth going everywhere. And rather than kind of tell mom and dad that we could potentially minimize some future treatment, we're just coaching mom and dad through the fact that, hey, if we can just wait a little longer, we can get this all in one fell swoop and do our comprehensive treatment at that time. And that's the same for our fee-for-service patients as our public assistance patients. If they would like to do a cosmetic phase 1, I still sometimes will try to talk them out of it, because then oftentimes really what you're treating mom rather than the patient. So these are really our main criteria. Is there damage to the tissue? Is there any kind of enamel damage, or do we have some kind of oral habit that we need to correct? And the first 2, we might do some fixed appliances. The 3rd, oral habits, we're thinking more tongue tamers or a thumb crib or a something like that. For oral habits, a lot of times we're not necessarily doing any kind of fixed treatment. Okay, so here's our Maple Grove crew with Dr. Sitsi Hungwei. And so here's one. This is a phase 1, and we do not do this very often, but this is a kind of a common treatment modality, becoming more common, and parents, mom really requested it. He has a little bit of gingival stripping on those lower anteriors because his lower incisors are being pushed out by the anterior crossbite. And mom wanted him to have Invisalign. And Invisalign has a product to treat phase 1. So we've probably done a number that I can count on one hand of these phase 1 with Invisalign. But that is what they requested. And if any of your parents, now you got plenty of other things to chase your kids around, to remember to just like bring their backpack to school or something like that. And now we're talking about worrying about clear aligners. But that's what you want to do. And he did it, and he ended up getting a nice result. It's a little bit more expensive option, but at the same time, for the right kids, in the right situation, if all the stars align, then it can be an okay option And for this little guy, it turned out to be just fine. You see the upper right primary canine is still a little bit in crossbite. We're not moving the right primary canine. So we'll see. We've got him out of anterior crossbite, but this certainly does not preclude him from getting future orthodontic treatment, or I certainly wouldn't promise that he's not going to need future treatment. It's just, one just cannot know that at this point. Here's Dr. Stephen Linden on our team with his son, Stephen Linden III, otherwise known as Trey. Okay, so this little guy, we're getting to this one because we're seeing, if you look on his lower right lateral incisor, tooth number 26, you can just see the root just wanting to, there's just a thin layer of attached tissue, of free tissue right there on that, because it's being pushed out by the upper right central incisor. So this is one where we're going to do treatment because we see that lower right lateral incisor is being pushed out. So we do just traditional fixed braces, and all of our patients, when they do treatment with us, get a Smile Orthodontics t-shirt. Here, Michi is holding up one of the breast cancer themed Smile Orthodontics t-shirts. So those are currently in circulation for our patients. And so this is after his phase 1, and I don't know, we probably spent 9 months or so doing our phase 1. And now, as you can see, now he's already getting in some of the rest of his dentition, and it's looking like he's in pretty good shape. And we did this a couple years ago. So now he comes back, and his mom would like him to do now full braces. And he looks pretty darn good. So this is one where mom was wanting it to be submitted to insurance for medical necessity, and we just said, you know, Mom, he looks good. This is just kind of a cosmetic elective if you want to do something, but really no treatment is required. And I would say that for phase 1 patients, this is not the normal for them to kind of, come out and look this good. This is not necessarily something we did. We fixed the anterior crossbite, and the rest of the teeth were just going to kind of drop in a good spot on their own. That is not anything we did. And here we've got Zach, who's in the back at one of our community events with Dr. DeChant and Natalia and Fuad, and we have on our team just a very diverse group that reflects the patient base that we see. So we've got patients speaking lots of different languages, and among our partners as well. We've got even a couple Karen speaking partners on our team. Okay, so we've got Angie and Luz. One of their patients brought back some little koalas from a trip to Australia. So we do enjoy, kind of forming relationships with our patients and finding out what they're up to, because they're going to be with us for a little bit of time. So this is another phase 1 case, and this young man came in, and we've got some tissue loss on the lower left incisor, tooth number 24. So we're going to do a phase 1, and we're going to do it with, the plan was to do fixed braces, but this young man came back for his banding appointment, and this is what he looked like. And it just took a long time. The dentist, one of my partners who saw him, just said, I don't know what just happened. This was a couple months ago, 2-3 months, and we were going to put some limited braces on to correct this anterior crossbite, and we didn't do anything, and here he is now. So sometimes when kids have a crossbite like this, and this is just, the upper left central is still just erupting, they have a little bit of functional shifting that they do to get into a maximum intercuspation. And so I'm not sure, but my best guess is that the erupting tooth number 10 just pushed tooth number 9 forward just enough to get it over that anterior crossbite so that he no longer had that, kind of functional shift into that maximum intercuspation. So he comes back to get his braces, I think it was 2-3 months later, and we said, actually, you don't need treatment. So how about we just see you back in 1 year? And as much as kids are excited to get braces, sometimes some of these younger kids, they might think they're excited, but they're not really excited. This kid was excited to leave and not have anything done. So, but sometimes we would do phase 1 treatment. And here would be another, we'll call it ectopic eruption, but it's also, there's some tissue damage happening to this gal's. Oh, so there I am with Krista. She's our location coordinator in Stillwater. And we're being real at that moment there. Right now, she is only biting on her lower incisors. She has some kind of traumatic occlusion on those lower incisors because her lateral incisors, if we go with the ABC teeth lettering, those lower laterals are supposed to come in seat number B. But instead, they don't come in seat number B. They come in not in seat number C. They're coming over in seat number D. They didn't buy a ticket to sit over there, but that is where they are. So you can see the right lateral incisor has pushed out the C and the D, and the left lateral incisor is about to do the very same thing. So we need to do a phase 1 treatment for her to not only get the laterals in the correct position and allow for normal eruption of the other teeth, but also just to prevent that tissue damage that's happening on those lower central incisors because they're just hitting in traumatic occlusion. They don't have neighbors to help hold up to the occlusal forces that are happening. So this little gal she's getting phase 1. She's probably 8 or so at the time. And I think we have her dentist just extract the lower left D for us, C and D, and we do a couple brackets. And I use this analogy a fair bit, and I don't know if you all saw one of my partners, Mike Morozak. He's good friends with Dr. Gesko, and so Dr. Morozak just came to go have coffee with Dr. Gesko in between sessions. Well, and Dr. Mike is about, I'm kind of tall, but he's taller than me. And so he is probably 6'6", 6'7". And Macy over there, who's our clinical operations lead, she's been with me for a long time. Macy is about 5 feet tall. And so we'll use this analogy when we think about moving teeth. Your incisors are Macy. And Mike is like a molar in this case. Or the other analogy is Mike is like a canine and Macy is the lateral. So when we think about the forces that we're going to use on teeth, for this patient, we're going to put in a lower lingual holding arch to anchor the arch so that we can then direct these laterals forward. So we've got a really light wire in there, and we've got some good solid anchorage in those molars while we correct the lower incisors, because we really don't have much else to hang on to there. So she's excited. This took a while. We probably spent 1.5 years in phase 1 to get her to this point where we've got the lower anteriors aligned in a reasonable position. And Dad, I remember him thinking, okay, well, this is pretty much comprehensive. We're all done now. Well, those incisors, they came from a long ways away. They are going to want to go back, and we can't hold her in some kind of fixed retention. She has more growth and development to do. You can't give her an Essex retainer Even a Holly retainer is going to impede the eruption of teeth, so she's got a lot of growing left to do. She ended up having a lower lingual holding arch in for another year. So here she's had a year and a half of braces, just on the lower arch. She's had a lower lingual holding arch for a year. And then I think that comes out, and then now we're seeing her, and she's probably 12, 13 at this time. And you can see that lower incisor relapse a little bit, which was, I would say, fairly predictable and to be expected. And so now we're going to just bracket everything. And you see Jenny wearing her Smile Orthodontics t-shirt while on vacation. And so we got everything bracketed. The thing you'll notice is the lower right 5, or tooth number 29, is rotated about 90 degrees. So, that's stuff that bugs us in the dental world. We're looking at thinking, okay, now that tooth finally erupted. Now we got to bring in the tooth number 29, and we got to rotate it. And so we finish her up, and you can see there still is that little bit of tissue damage on the lower incisors. And I would say that the lower right 5, the picture is a touch foggy, the occlusal of the lower, but on the lower right, you could just see that this is just not as fully rotated as we would like. But she had another 18 plus months of phase 2 treatment for us to get her to this point. And so she was so upset and crying, just wanted her braces off. And so when we do that phase 1 treatment, kids only have a limited amount of patience and time with us. As much as we might think that kids want to come to the orthodontic office and it's fun, it ain't that fun. Kids they're excited the first 6 months, and then after that the excitement wears off pretty quickly. So we said, okay, we hear you, that's fine. We're going to just have to live with the fact that is rotated about 35, 45 degrees on the lower right, second premolar, and let's just be done. And she got a nice result, and it's stable, and now those lower incisors, they have their neighbors, all the dentitions in, and she's got a nice result. And then here is our team at one of our summer town hall meetings outside of the university club. Just looks like a colorful bunch of people right there. Okay, so the other part about phase 1 is just being realistic as far as what you can accomplish. And that's a little bit of our job to tamp down, for mom or dad, hey, let's just wait, because you can do more harm than good sometimes by intervening. Sometimes less is more, and I would say in some of these phase 1 cases, less is more. These were a couple cases that we inherited from another office where they were trying to, we'll call it, do maybe a little too much. Right here we've got a couple of our partners who are in dental school. They worked with us. Khalid and Lahiri are both now second-year dental students, so we're proud of that they worked with us in a clinical support role, and then we're able to kind of launch them into their dental career, and so they're currently both second years at the University of Minnesota. But this is something that you all see, I'm sure, all the time, is mom or dad comes in and says, my son has a tooth growing in behind the other ones. What do I do? This is a problem. They've got rows of teeth. They're shark teeth. We need to do something. We need to do something now. And fortunately, if you all want, we are more than happy to have those conversations. And so you don't have to take up any more time, thought, brain power. You could just say, why don't you just go see Doug over at Smile Orthodontics, and they can kind of talk to you about the different options. And probably, we would start with, someone young like this with some realistic expectations for the amount of crowding that this young man has. But what ended up happening was he did a year and a half of orthodontic treatment. And so here's where he ends up. The 3 lower incisors are in about the same place. He probably had an appointment with his dentist or dental therapist where he was probably pretty uncomfortable getting his C's extracted because taking the C's out early when they are not ready to be exfoliated, they don't come out easy. I've done a lot of them and I know that. So that's not a fun appointment. And we spend all this time, and where is he? He's in about the same place instead of thinking, we might end up extracting a lower incisor and maybe 2 upper premolars to resolve his crowding and just doing it all in phase 1. Well, now we're sure we're extracting a lower incisor because we've lost all of the tissue on that lower right central incisor. So this guy spent a lot of time in braces and just did not advance anywhere with his phase 1 treatment. However, these 2 young ladies, Ava and Carol, they did advance. They passed their dental assisting exam, and they've got their little pictures to prove it. Here is another phase 1 patient that we inherited. And same thing, so we're looking at her face. We start from the biggest and kind of work our way in. And I think what you notice is if you look at her upper jaw relative to her lower jaw, she has this tiny little lower jaw. She's got her nasolabial angle, so just kind of where her nose meets her upper lip, is already a little bit obtuse. So we would be thinking, gosh, we probably don't want to extract on the upper arch because we don't want her upper lip coming forward. Really, just as I'm looking at her pictures, I'm thinking, okay, this is a small lower jaw problem. And, patients are going to come into you like this, and they've got this big overjet, and you think, well, we've got to do something. Let's get in there and fix this big overjet. But that isn't always the right thing to do. So here she is. This is her Ceph, and you can see that amount of overjet she has. Our team sponsored a little basketball camp in St. Paul this past summer. So here we've got some basketball players in their Smile Ortho merch. But when we're seeing this gal, you could still see that she has a small lower jaw. She has a retruded mandible. So now, this is her initial Panorex, and I think the plan, from reading the previous provider's notes, was to get in all of the lower teeth. That was the objective with phase 1 treatment. So get the lower teeth into the arch and kind of resolve the overbite and overjet. So great, we got all the lower teeth in. But what did we do to the 7s, or the lower second molars? So we've avoided extraction in the lower arch, but have we really? If we were to kind of play it out, I think where this gal ends up, she probably is well, we'll get to that in a sec, because you get to see more. But so, okay, so now she's done with her phase 1. Great, non-extraction in the lower arch, perfect. And the upper teeth are all in. But now what happens is they spent a lot of time, so now phase 1 is going to roll right into phase 2. So now here's the patient. Those lower 7s are still not great, but we're doing treatment. We're now 4 years in. Oh, now we got to get the 7s in. So we've got the lower left second molar in, but at what cost? You can see a significant periodontal defect on that second molar, and the right second molar is gone. But you can see that we tried to pull in the second molar here because we've opened up a space here as we were trying to pull in the second molar, all in hopes of avoiding extractions, and oops, it looks like we've had to do an extraction of a lower right second molar. And now we've got a wisdom tooth that's just, that's not ever going to really be functional. That's just going to be kind of a, I didn't even know what that's going to be, just like a little golf ball back there in the kind of ramus of her mandible. So, and if we look at the Ceph when we first saw her, we're still back at that same, the pattern, her growth pattern, the pattern is the pattern, and she still just has a retruded lower jaw. So just a small mandible. And that's fine, but we would just want to know that going into it so we could be thinking about what's our plan for her. And then when we do the Ceph tracing, a lot of times these numbers, we're not treating people to numbers, we're treating people to their dental facial balance, but the numbers just give us a little bit of an insight into their particular growth. And in her case, we're looking at the number that measures the fixed points on her skeleton relative to her lower jaw, and seeing that her mandible is in fact retruded. And even her upper jaw is back a little bit further than would be considered ideal if we're treating to the numbers. Okay, so we'll just go back. But really, what probably this gal should have done, she's still in treatment. She's going to need to have orthodontic surgery when she's old enough. She's a couple years away from that, but in the process, we've burned through 5 years of treatment for her, and she's going to need treatment again when she's 18, or the conversation we've had with her is just going to live with the overjet that's going to be resulting, and it's going to be still a significant overjet, and that's fine. It's just as long as people know that that's where they are, and those are the options. But it's well intentioned maybe to do phase one to fix things, but sometimes it's better to just leave well enough alone. And that's probably of our patient population, we are probably doing a phase one intervention for less than 5%. I think it's 2 or 3% right now. Here's our Maplewood crew with our newest Dr. Sean Odell. And this would be the other reason that we would be thinking about some kind of phase one intervention, is because of this patient's tongue habit. Tongues can just do crazy things. It is such a strong muscle, and there is no orthodontic appliance that we have that's really going to overpower someone's tongue. We can just kind of only hope to contain it a little bit or retrain it. So this would be an indication for doing something like some tongue tamers, which are little spurs that you bond to the lower end, in her case, probably to the lower centrals and the laterals, and just get her to just think about posturing her tongue in a little different manner. So we're going to look at different facial types, and then the role that the tongue plays, and kind of see how that works in the different facial types. But maybe just take a quick pause and see if there are other questions. What other questions do you have? Yes?
Based on the prior film, under infected mandible, would hurt a client doing a bad surgery or not?
So we don't do many of those fixed functional appliances. For a Herbst appliance, for all of you that are not familiar, it's an appliance that is fixed in the patient's mouth and bonded to their molars, and it has a telescoping arms on the sides. Sometimes you might see things like a Forceps or Power Scope, which are bonded to the wires or fixed to the wires. All of them work kind of in the same way, which is artificially posturing the lower jaw forward and then hoping that in the future the condyle will grow up into the fossa of the patient's skull as they age. So different schools of thought on that. Some people feel like that's, there are plenty of people that do Herbst appliances. Is very difficult on the patients, those particular appliances. And I would say, in my opinion, it's somewhat unstable. And we have patients, we call it sometimes a Sunday bite, where you can kind of get them into this, a muscular position where they're comfortable somewhat, but really their jaw's not seated properly in the fossa. And that is really what we're doing most of the time with our Class 2 elastics. We're just artificially getting people to kind of slide the lower jaw forward and establish them in a musculoskeletally stable position. A Herbst is just kind of a more aggressive form of that. Yeah.
Would you rather us take a pano or you take a panoramic?
We almost always take our own panoramic so that we have a nice, fresh image, because we don't know really sometimes what happened between the time you saw them and you took your pan and the time we saw them. There might have been some significant restorative done, but at the same time, so I would just take images that are appropriate for you. And I think, we would do the same. And then I would just encourage all of you just to, when it's appropriate for your patients, take the images that you need for your patients. Or if you need us to do that, we're certainly happy to do that. But that's how we think about that. Yes?
I was wondering what you feel about prior canine extractions when there's a lot of crowding. I mean, I've worked in a public health clinic where a lot of providers do it because a lot of these kids aren't going to get braces. But I also think you have a loss of space that way. So just what do you think about that?
Yeah, absolutely. You still are going to have the same amount of crowding. What you get is maybe a little bit of a happy mom or dad, because now the crowding has somewhat unraveled. The kid ain't happy because they just had 4 primary teeth extracted. And then ultimately, you're going to be in the same place, a couple years out. Probably the spot where you can affect the spacing the most is going to be saving the E-spaces. So if you're helping the pair, in your practice, if you place a lower lingual holding arch, that is probably the best thing that you all could do orthodontically for a kid who has crowding. We're happy to place those as well, but if that's something that you want to do, that would be a really nice service before they lose the lower E's to place a lower lingual holding arch. Yes?
Yeah, Shelley's question about for referral, do you want them to have a panel sent with that, or can they have a referral without a panel?
They can have a referral without a panel. They can just call. They can do whatever. They can just walk in. We'll figure that part out. But we're really taking full records on all of our patients, unless they have a Panorex that comes in and we look at it, and one of the doctors looks at it and says, okay, hey, no, this is recent. This is good. There isn't anything out of the ordinary on it. We'll sometimes just import those into our records. Yes. Mm-hmm. Yeah, very, very well could be. So, I mean, that would be a great intervention if that were the case at the time, to just do that minimal intervention, go do a thumb crib, and just sit tight. Eliminate the oral habit, absolutely. Yeah. I'm sure it's certainly within the scope of practice of the dentist you're working with. I'm not sure if it's specifically, cementing bands, cementing appliances, but it certainly should be within the scope of practice for the dentist you're working with. And it is a very it's a nice service. They're comfortable with you already, and you can just send it, do a scan, do an impression, send it to the lab, and get the appliance. Chrissy.
All right, so dovetailing on that same
Yeah.
question that I had, I've already written it down, is, I want to say at what age, but that's the wrong question. At what stage of development do you need to address that thumb sucking with the prick?
I would say once you start to see it affecting the permanent dentition.
Okay.
So when kids are in the primary dentition and they have a thumb habit, I could just kind of think, hey, it'd be nice if we stopped. But once you start to see it affecting the permanent dentition, that's when I start to say, okay, let's see if we can't really crack this. And yep. And then usually you're just trying to get, first step is, hey, mom and dad, are you aware of this, that this is affecting the teeth in this way? How about you work on it? And then, a lot of times that resolves it, but it's hard to break. And sometimes, once kids are a smidge older, and they're going to school, they want to stop themselves too. So even a thumb crib, most of the time can stop it, but some kids who are really, they'll work their way around a thumb crib. Absolutely. And so we will sometimes cut the thumb crib to make it a little bit more, kind of sharp or abrasive to their thumb to keep the thumb out. But, it's really an adjunct. They have to also want to stop too. Okay. Tongue. So facial types. And then we're going to look at it with respect to the tongue. And I think when you see the different facial types, you'll kind of say, oh yeah, I see that. So we do have, here's Naomi showing off our little coffee and tea bar for our patients too. Parents come in, we try to make it a welcoming environment, and they're going to have to be there for a little bit. We try to make the best of it. So, but this particular patient has really nice, normal facial balance. If you look at her face, good symmetry, profile, the facial proportions are all, really nice. She just has this little bit of spacing that she'd like fixed. Well, sure, we can fix the spacing, but there's something there that's really big on that far right picture here. That's a really big tongue. That's really, really big. So what do you think, Dr. Quillen? Should I just move this out of the way for you guys a little bit here? Okay. Okay. So we can try and fix a spacing for her. You could do clear aligners, you could do fixed braces, but she actually needs a tongue reduction surgery. That ain't fun either. I mean, taking out primary C's is not great. Tongue reduction surgery is even less fun. But she has, if we look at her Seth, she has good dental facial balance, orthognathic or just normal position of the jaws, and we call it just normal musculature, her muscles of mastication. So she's doing great. She just has a really big tongue that is causing that spacing. So we're not going to be able to do anything until she gets that addressed. No orthodontic things are going to help her because it's going to just immediately relapse. Yes? You could just probably watch it on YouTube. I'd do it maybe before lunch, not after. Yeah. Mm-hmm. Yep, just reduce the lateral borders of the tongue on both sides. Oral surgery. Mm-hmm. Yes. Well, she's an adult, so she's post-expansion, but right now, if you look at her face and you kind of zoom in on her smile and her incisor display. I mean, it's just perfect. It's just the one thing that's just kind of, we wouldn't want to expand to fit the size of the tongue. The tongue is kind of the etiology of her spacing. Has not yet. And again, it's cosmetic and elective. I don't know that she would have, we're making this more difficult. She's looking and she probably just said, I could just do Smile Direct Club. This is easy. I just have a little bit of spacing. I just want to get this fixed. Yeah, well, we don't, we might as well just, if she wants to do that, she might as well just go drive down Highway 55 here and throw $2,000 out the window. Because it is, unless we fix the underlying etiology, that's just not going to be stable. But in all other respects, she's just very normal. So now, here is our Minneapolis crew, Dr. Linden, Dr. Steve Clifford, and our Minneapolis squad. This gal, she is what we would call hypodivergent, kind of short face, strong muscle, and look what her tongue is doing to those lower incisors. Same thing, kind of big tongue issues, and this is what the tongue is doing to this particular facial type. It is just splaying those incisors out to the point where she's gonna lose them. So she might think that orthodontics is her concern. I'm kind of thinking you might not have those lower front teeth much longer. And so if we look at it, so she is what you might look at and feel like she's overclosed. So hypodivergent, she has a shorter face height and really strong jaw musculature. So as she's overclosed, her tongue, which is also extra large, has only one place to go, and that's forward. And that's then pushing those lower anteriors right out of the jawbone. So for our hypodivergent, strong musculature patients, we can do a lot of things to them orthodontically. They're less likely to have extractions because we want to open up their bite. And everything we're doing is to try and open up their bite. And their strong jaw muscles are fighting against us. So these would be the type of patients who come in and they say, I would like to do clear aligners. And we think, gosh, clear aligners cover the chewing surfaces of the teeth. We need to open up this patient's bite. Fixed braces is going to be better because fixed braces, the first movement that happens to teeth when we apply fixed braces to them, the first movement is up and erupting the teeth. So in a patient like this, we're doing everything we can in our hypodivergent strong muscle patients to erupt the teeth. So short face, strong muscle, hypodivergent. The opposite of that is hyperdivergent, long face, weak muscle patient. So now look what the tongue is doing to our hyperdivergent patient. And so now we've seen a couple cephs, so you probably know what hers is going to look like when we click to it on the next slide. But look at what her tongue is doing to those lower anterior teeth. It's not splaying them out because she's not overclosed. She's just has her mouth hanging open. And these would be people you would see with the kind of long face, weak muscle patients, that facial type, where their mouth is just hanging open more. They're going to be more prone to an anterior open bite. And in her case, with this large tongue, the tongue is just really wreaking havoc with her kind of vertical growth pattern. And here's Brittany, Angela, and Andrea in our Maplewood office. Okay, so there she is. And kind of as you would expect, you're looking at this mandibular plane angle here, and it's kind of like we're falling off a table here. Her face is just, she just has a longer face, weaker jaw muscles, and the tongue is just, almost spilling out of her mouth. Question? Yeah, sometimes some people with difficulty breathing, tonsils and adenoids, that can cause mouth breathing, and then having that kind of long face, open mouth, open anterior open bite. So occasionally we'll do referrals for tonsils and adenoids, but that's not that common. I'd say. Mm-hmm. Mm-hmm. Yeah, I'm not sure necessarily allergy related, but definitely tonsils and adenoids, and sometimes sleep-related breathing disorders cause people to have that kind of longer face, anterior open bite. So this is not one that is going to be treated orthodontically. This is a significant skeletal discrepancy. She's going to, when she is older, this is going to be an orthodontic surgery case. And it's always disappointing for patients to hear. And so, you know, we do our best to explain that to them. And when possible, we will do dental camouflage treatments to mask some certain underlying skeletal discrepancies. But this is just not one where we're going to be able to do that. And so for those patients, then we're looking to start treatment around maybe age 17, 18 in a girl, 18, 19 in a boy. And depending on their growth, you're doing orthodontic treatment for a year, and then orthodontic surgery, and then, you know, another 6 months to a year of braces to wrap it up. Yes?
Is there something, I'm thinking in a case where we would refer that we could maybe set kind of that precedent or those expectations that, knowing that we may not be able to take them just going through this skeletal situation or an ortho thing, something that we could, either some guidelines or some basis or something to at least help guide those patients' expectations when they're thinking of like this.
I think you could tell them that it looks like your bite might be even more related to the position of your jaws and not necessarily just to your teeth. So then I'd go just get this looked at and see if there's something that can be done dentally, or if it's something that you might actually need to do a jaw surgery for. And you know, when we're telling mom or dad that, and they're hearing it for the first time from us, it still just takes a little bit to set in. And with our surgery patients, definitely happens where we'll they'll have the consult with the surgeon, because we require that before we start treatment, and they get kind of halfway done, or they're getting close. We say, okay, now it's time to go see the surgeon. And say, actually, we decided we don't want to do that. Okay, well, that's not how it works, because when we do surgery for patients, we actually make them look worse before they look better with the surgery. And that's happened many times, and then sometimes they might think they want to do it, and there have been, you know, patients who bail. There's just mom or dad are not on board with it, even though the child is an adult. Mom or dad says, you're not doing this. So, you know, patients want orthodontic treatment. Dr. Quillen and I were talking earlier. They might want treatment, but we got to be realistic, and our new protocol is to just call the general dentist's office and verify that they were in and that there's no treatment that's needed, because, you know, we just have patients might mean well, but 6 months ago, they say, I was just in, 6 months ago. Actually, that meant 60 months ago. I mean, it is not... whether it's imperfect memory or whatever it is, it's oftentimes not accurate. So what we try to do is call find out who their general dentist is, and then, you know, people sometimes don't even know who their general dentist is. So, okay, let's get out Google, what street is it on? And then, you know, okay, does it look like this? Does it look like that? Oh yeah, that's the place. And then, do the picture. Oh yeah, that's Dr. So-and-so. That's the person I see. And then we can call the clinic. And then, turns out they have not been in for a while, or they have some other restorative needs. So we try to be, realistic with our patients in that they're not always as truthful with us as they could be. And so here's our team on the upper left. When we inherited this other office, we had a bunch of orthodontic models that needed to be broken up. So I think we paid some kids in, Cheryl, our location coordinator, paid her kids in McDonald's gift certificates to take a hammer and to chop up some orthodontic models. The kids had a great time, and they got a McDonald's gift card out of the deal. But so this gal, she's 17, and this kind of looks straightforward, like, okay, she's got some crowding, kind of relatively normal dental facial balance. She's got a pretty big smile. A little different to see, and this is maybe a tip-off, to see the upper central incisors at different lengths. So you might see them crowded in different planes of space, but here her upper incisors are at different lengths. And so, question for you, in your older patients, when you see incisors that are at a different length, what does that typically mean? Bone loss. So check that kind of bone loss out on a 17-year-old. Super disappointing. She might want orthodontic treatment, but that is not going to be in her best interest to do any kind of orthodontic treatment. If you look at the bone loss in the anterior, you've got significant vertical defects, and in the posterior, you've got furcation involvement in somebody that's 17 years old. Yes.
Do you have people that have issue with tongue rings?
Some have seen it tongue rings wear. Yeah, seen it chip teeth, and also especially wear the tissue on the lower incisors. Not so much on the lateral. But so, I mean, this is it could be, and I can't remember this particular case, if she'd maybe ever been to a dentist in her life, but she has some significant pair that's probably going to preclude her from ever being able to do orthodontic treatment. It's going to be really heroic if she gets to keep these teeth for the rest of her life. And this isn't even, this is one where it's a little bit of, we wouldn't treat them, but you, I'm sure, all see, and we see tons of patients who come in with bridges and implants and missing posterior teeth, and had implants done in Mexico, and now they just want their front teeth straightened. And we got to be realistic about the types of treatment we're doing for patients, and sometimes we're not able to deliver what patients want, but it might not be in their best interest to do the treatment that they want. And for this young gal, that is certainly the case. So, any other questions up to this point? Yeah.
Okay, so I've had a patient of ours, went into braces, came back 6 months later, decay all over the place. Or so a year later. And so I called up the orthodontist office and told them to take her out of bracket. And they said, which ones? And I said, all of them. And I just wanted to know from your opinion, where does the responsibility lie? Because I feel like it should be the orthodontist who's seeing that person every month to notice that there's decay with them. To be proactive, not being opposite where they're like, what do you mean? Why do you have to take them out of braces, when they've got rampant decay?
Yeah, I mean, so what we've, kind of tell our dentists is really that the general dentist office or the dental therapist gets to decide. If they say the braces have to come off, they're coming off. We can always put them back on. So that's not a deal. But if you say, hey, this is in the patient's best interest, let's just take them all off. We'll sometimes take off a bracket or two for people that the dentist just did one yesterday. Tooth number 30 needs a restoration. Great. Clip the wire, take off the bracket. But when the general dentist or the dental therapist, and you should feel so empowered, hey, this is in the patient's best interest, let's just discontinue orthodontic treatment. For us, what we'll do is we'll put patients in our oral hygiene program, which is then seeing them every 4 weeks, and we tell mom and dad, we're not even really going to be advancing their treatment at this visit. All we're going to be having them do is come in and make sure that their oral hygiene is on track and that they're, we may change the colors for them, but it's a little bit of a, for mom and dad, it's an extra visit that they wouldn't have to make, and so it's a little bit of a pain for them, and just kind of making everybody feel like, hey, we got to have a commitment to do this, otherwise we're going to discontinue treatment. And then I think when we're seeing decalcification and actual decay, we're then just doing a little bit of a, okay, where's an off-ramp? How can we get them, if we do another 2-3 months, can we get them to just a little more stable spot, because there might not be another opportunity to get braces back on, so it's just trying to get them to the end. Oh yeah, absolutely. Usually it's 6 months, 6 months or a year. 4 weeks is not really going to be enough time. More often what we're doing is getting clearance from their general dentist. So essentially say, yeah, you've got oral hygiene issues, you need to get perio and restorative clearance from your general dentist. And so we've got kind of a master tracker that has all of our patients and kind of the status as they're coming through, and it's probably every, I don't know, 1 out of 10 needs perio clearance from general dentist, needs some restorative clearance from general dentist prior to starting. Yeah. So really we're just looking for, do they have any existing restorative that needs to be done? And is there, were they in for a hygiene visit recently? And is their oral hygiene status sufficient to do orthodontic treatment?
You see periodontal diagnosis for adults? I'm going to go back to the
Yeah.
yeah.
For periodontal, yeah. Mm-hmm.
Type 1,
Mm-hmm.
4, 12, 4,
Mm-hmm. I mean,
that'd be helpful.
it could, but at the same time, it's also maybe just, green light, red light, and at the same time, just know that at any point, we're kind of putting up the yellow light caution flag, but if at any point you say, hey, it's red light, stop, then we stop, and we can always restart once they get their act together. Okay, so oftentimes people want to know, am I going to have teeth out for braces? So just a couple of extraction patterns that we might do. This is Carol wearing our little camera that we use to record procedures. Yes? Yes? No, we'd let their insurance, if they're on a, insurances, some pay monthly, some pay quarterly, we just let the insurance company know, patient stop treatment. Sometimes it might even be for, patients are like, I'm moving to Africa or something like that. Actually, it's more like, I have moved to Africa, I am not here. And then it's, okay, Delta Dental, hey, sorry, this person, they moved 3 months ago, we last saw them on this date, and then we're going to discontinue treatment until they return. So Dorothy holds a record for being my longest, oldest orthodontic patient. She's a friend of my grandmother's, and she said Doug, I really want to do braces to fix my lower crowding. Would it be crazy to do braces at my age? And I said, yes, it would be. She said, well, I really want to do it. I said, you can, but it would be crazy. She said, okay, well, I want to do it. Okay. So we just did some lower braces for her, and we extracted a lower incisor. So anytime we do that, we're letting people know that you're going to have a little bit of recession, especially you're going to have a gingival defect. And especially in somebody who's older. I think when we did this, she was 83, 84, something like that. So she's finishing around age 85. And then here's a couple of our younger people, a little local beanbag tournament, juxtaposed with Dorothy. Here is one. Gosh, maybe this is Zach and Jenny at last year's dental therapy conference. So this guy is a borderline case where we're maybe thinking surgery for him because of his retrusive mandible. But there are some cases where we can do this, a camouflage treatment where we're going to do some extractions. You can see he's solidly class 2 in his molars and canines. And, doing orthognathic surgery is a big deal. And most people do not want to do it. There are some cases when you cannot get around it, but there are some cases when you can kind of do a camouflage treatment, just kind of shimmy by. Not everybody's looking at their profile. Most of us don't see our profile in the mirror ever, but you just kind of do know, like, something's not right. But so for this young man, what we ended up doing was just extracting upper first buys. And then how he got around it with the chin is a little beard at the bottom to kind of just give him a little stronger chin. Instead of a genioplasty, this is one that you can kind of do at home to add a little volume to your chin. And then we'll squat up there in the corner. Sometimes we'll do a little, there's been a lot of pushing of kids around in strollers or holding of babies while moms are at orthodontic appointments. Okay, so this, then when you do insurance, when Christine is not doing a little dance party, that electronic dance thing, she's doing our revenue cycle. So that is when you're dealing with a lot of insurance companies, just working with United Healthcare and Delta and Health Partners. But so this young man had treatment at another orthodontic practice, and he had some relapse. And so then he'd gotten a couple other opinions of how he's going to fix his relapse and, wondered what he should do. And I'm looking and thinking, gosh, you just had braces not that long ago, and now you've got this relapse? That seems kind of strange. So I asked to see his retainers. He had upper-lower Essex retainers. What do you think happened here that would have caused this relapse? I'll show you the pan. So this is wearing an upper Essex that was trimmed to the distal of the 6s and not covering the 7s. So the upper second molars have hyper-erupted. So now he's looking at doing retreatment, closing the anterior open bite, and what I thought was, we got some perfectly good third molars up there that might end up having to be erupted. So we just did a little digital mock-up for his dentist, because now we're talking about extracting upper second molars. That's a little out of the ordinary, and if we're going to do an extraction pattern that's that different, I just said I wanted to show it to the dentist so they didn't say, you're going to extract 2 and 15? So what I did is on our digital model, I took 2 and 15 and I just intruded them. Took his models, printed them out after intruding 2 and 15, and he kind of drops into a spot where it looks like probably when he got his braces off. It was really just, he was wearing his retainers, it just, they weren't covering 2 and 15. So then we did treatment for him. He's got a little bit of a gingival defect, upper ones. We had to take his braces off early because he was going into the service. But this was probably, I think, less than, it was maybe 9 months of treatment. he was going into the service, and you can see there's a little space on the upper right between the canine and the premolar, and then a little space on lower. But so we ended up finishing aligners, but we didn't see him because he shipped out. But that was an example of just doing a quick little digital mock-up to see where we would potentially end up. Our Stillwater office doesn't have a very good break room. We're rectifying that, but people are having to kind of eat lunch in the hall. All right, so this is just kind of more your standard extraction pattern. On the left, you see our team at one of our last town halls. We had a little building exercise, team building. They were doing literal building with Lego blocks. And so for this particular patient, she came to us, she had the fours out, she was kind of ready to go, and that makes sense. She's, crowding in both arches. And so what we're doing for her is just standard treatment mechanics. But if you have a lot of crowding and then good treatment mechanics, and then like we have is a customized digital plan for all of our patients, you can get them going pretty quickly. Here's Dr. Clifford and Dr. Linden. So here this is day one, she gets her braces on, and at that time, now we are setting her up for her digital treatment plan. And if you look and you see our patients in your offices, these wires have some little bends in them. These aren't bends that we place by hand. These are bends that were done by a robot down in Texas. So all of our patients get these custom arch wires that are bent for them. And so there's tip and torque and all kinds of little movements prescribed in for the patient. And so she's probably at this point, this is just maybe 6 months in. So we went from here to here in about 6 months. So she's really excited, thinking she's going to be getting her braces off, the next day. But like anything, there's kind of that initial excitement, and you make a lot of progress. But then it just takes still a little while to kind of dial the rest of it in. But so this is what our digital treatment plans look like, and this allows us to have this team-based approach to care because we're all able to see the plan. So we design the plan, we know where we're going, and some of you who maybe follows Stephen Covey, begin with the end in mind. Dr. Gesko, who I served on the board with, he was my mentor. I remember when we would go into these case conferences at the Board of Dentistry, he'd say, Doug, okay, what we're going to do is we're just going to begin with the end in mind. We got the person coming in. What are we thinking about, how we're going to end up? And then, that would be how we'd conduct our case conferences. But same thing for our patients here. We've got a digital plan, so we know where we're going. We've got a roadmap to get us to done for this patient. And then here she is when she's all done. And I think this was a year and a half. So a year and a half for someone with 4 buys extracted is a pretty nice treatment time. And she was just tickled to be done. And then I think we've got some of our St. Paul crew here at one of our work events. And then we will just do maybe a quick jaw surgery patient. So here's our clinical support team. We've got for every one assistant, we kind of have a half FTE of clinical support just in the background, kind of getting things, sterilizing, making sure that the trains run on time. But this particular young man, this is not something that just braces alone or braces plus extractions are going to fix. If you look at his skeletal type, he is a strong muscle, hypodivergent patient with a prognathic mandible. And he's got kind of just a supernumerary lower right premolar, and the upper right second molar, tooth number 2, has a significant cavity that ends up, he's going to lose that tooth, or maybe elected to have that out. So he's going to get, before his orthodontic treatment, he's getting his wisdom teeth out, he's getting tooth number 2 out, and he's getting this impacted premolar out. Another fun little work event with our team, throwing some bean bags. But if you look at this guy's skeletal profile, there's where we see overclosed, hypodivergent, prognathic mandible, and his dental facial balance is off due to this prognathic mandible. So here he is pre-surgically. So we actually make him just look a little bit worse pre-surgically. Because now when people are in this space, what it is his upper incisors were flaring forward trying to meet the lower incisors, and his lower incisors were tipping back trying to meet the upper. Well, now we want to get them into the ideal position, so we're now uprighting his lower incisors, and we're decompensating his upper incisors, and we're getting him into kind of a pre-surgical position. And so here he is pre-surgically, and then when he comes back, well, actually, we get to see what we did for surgery. We did a maxillary advancement, so this is an upper jaw and lower jaw surgery. So all the surgeons now do digital plans. So we know we're going to move the upper jaw forward, and the lower jaw is getting set back. And we approve the surgical plan, and then they go. And when he comes back, he is a totally different dude. His face looks completely different. And this is just immediately post-surgical. I think we're 4 weeks post-surgery. And his bite is now not quite right. Now we just have to settle his bite and do our final alignment. And there's Dr. DeChant. She enjoys boating on Lake Minnetonka. If any of you are out there, look for her in her Smile Orthodontics t-shirt. And then here he is when he's done. We don't have that upper right first molar all the way seated. We're going to just let gravity do its thing. We can kind of see he's still missing that tooth on the second molar on the upper right. And this was probably about a 2-year treatment for him. So about a year in braces, maybe probably even longer, about 15 months in braces, surgery, and then another 6-8 months to wrap it up. All right. Questions? Yeah.
What's the post-op on that, like from surgery day to hard crest day?
Surgery day to what?
Hard crest day, like what are they?
Oh,
Like what?
I think he's doing muffins for a little while. It is probably 2 months. But yeah, I mean, when patients come back from the surgery, they're miserable. It's really rough. They've got 2 weeks of being really miserable, and then from there it starts getting better. That's just your growth. And so that's kind of the equivalent of, when I was younger, if my mom and dad said, hey, we're going to put books on your head to keep you from growing. There's just a certain amount of growth that's just programmed into my height, into this kid's, into his jaw. The mandible is just like you need long bone in your body. You can do a chin cup and just try to hold that lower jaw back there, but similarly, you can't stretch someone out. You can't say, well, we'll just stretch out his maxilla with some face mask protraction. We'll just pull that forward. That's for the vertically challenged folks. We can't just stretch people and make them taller. So, quick little, case reviews. We're running a little shorter on time, so I would have maybe spent a little more time, but this is my daughter, and I told my team that I was a little late this morning because I have, in addition to my main job at Smile Orthodontics, I have a new job this year. I'm the assistant copy editor to my daughter's school newspaper. So when the copy editor needs help, I, as the assistant, get roped in. So last night I was helping write an article about girls in STEM for the St. Paul Academy School newspaper. But so this would be just, if we just look at our cases, this is the kind of stuff that you are all seeing every day. And we'll just do this one guy. But so looks kind of straightforward, but what's going on the upper left? So we've got a molar that is, I would say, I mean, ankylosed. So now we have to kind of make these decisions like, what are we going to do? He really needs, if I'm looking at his profile and I'm looking at the amount of crowding, you see how his incisors are really tipped out. If we try to bring in the upper canines, the upper incisors are going to flare out even more. So I'm looking at him thinking, all right, 4 bicuspid extraction case, whether we're doing the first premolars, the second premolars, that's kind of like a potato potentially. But then I see this and go, wait a minute. We got a upper left first molar there that if we take out first premolars or second premolars, we're going to have kind of a big space there. And then you can also see the lower second molars almost look like they might be a little bit stuck. So these would be the kind of things that you are all seeing just kind of in your everyday practice. Just these little, you're seeing the most difficult, the most interesting cases. And we kind of like those cases too. So thank you for sending them to us. But we're probably looking at maybe extracting the second premolars and then extracting that upper left first molar and substituting in the second molar, which is really an uncommon extraction pattern. But at the same time, I think we could try to subluxate that upper left first molar, and we're not really going to know if that's going to come in. And any mechanics that we put on that is going to intrude the teeth on the other side. If we think of the Dr. Mike and Macy analogy, that's like Dr. Mike buried in the sand up there. And so if we're going to try to pull him up, we better have a really good plan, because it's going to be a lot of force to bring a molar up that's impacted like that. And if it's ankylosed, then we're really stuck. So, other last questions? I'm just going to buzz through and leave. There's my email and cell. Feel free. Yes, question.
Maybe it's just a little bit of but just in like the teeth world, when it's not super crazy case like a stage 1, but a good stage 2 or normal case, what age do they come say hello? Because some parents are like knocking at my door, like, I want my kid to be seen. I'm like, bro, chill. I know it's not time yet, but like, what's a good like?
Yeah, so I tell people all the time, so girls, it's usually 11 to 12, boys kind of 12 to 13. But at the same time, there are so many kids walking around with braces that are age 8 and 9. You're not going to win that conversation with mom or dad. You can kind of just say, hey, it doesn't look like your child would necessarily benefit from a phase 1 treatment, but you're certainly welcome to do that. Again, orthodontics at any stage is really cosmetic and elective. So people do not need to do this, but at the same time, most people want it, and it's a little bit of a rite of passage. But it's typically girls 11 to 12, boys 12 to 13. Okay, thank you all so very much for having us. We appreciate it.